Just to now talk about the session that's about to start, I'm going to hand over to my colleague Dr. Zaman for an introduction to Professor Chatty. But we're going to start the day with a speaker who will approach the themes of the symposium from outside public health. And Professor Chatty is a social anthropologist whose life and work has been focused on this region. And as you know, the approach and the methodology of social anthropology is distinctive in its commitment to participation and engagement with and in the lives of others. And the increasing role of anthropology in public health research testifies to the value, indeed to the necessity, of anthropological perspectives on complex health issues, whether these are at the level of the individual life or at the level of the structures of healthcare. So it's for this reason that medical anthropology has been one of the core component disciplines that we've embedded in RESCAP-MED. And with that kind of introduction to prepare you for a perspective that will be rather different to those that you've had so far, I'm going to hand over to Dr. Zaman and then to Professor Chatty.
Good morning. My name is Zaman. I work with Newcastle University. I'm actually the co-investigator of the RESCAP-MED project that's running this workshop. So it's my pleasure to introduce Professor Chatty. She's a professor of anthropology at the University of Oxford. She's also the former director of the Refugee Studies Center. Professor Chatty, as Professor Phillimore mentioned, that has been working in the Middle East for several years. Our research interests include forced migration and development issues, such as conservation-induced displacement, tribal resettlement, modern technology and social change, gender and development, and the impact of prolonged conflict on refugee young people. Professor Chatty has worked in various universities in the United States, Lebanon, Syria, and Oman. She also has worked with a number of development organizations, including UNDP, UNICEF, and FAO. As you have seen in the program, today Professor Chatty will be speaking on the issues around healthcare and humanitarian emergencies in the Middle East. So, Professor Chatty, over to you, please.
Thank you very much for this very kind introduction. And also I would like to thank both Professor Abdullah and Peter Fillmore, as well as the whole of the RESCAP-MED team for inviting me. As Peter knows, when I received the invitation, I wrote back and said, are you sure you want to invite me? I don't do medicine. I think I put it that way. As a social anthropologist, I work on the edges of so many different fields. And on reflection, I thought, well, you know, I probably do have a few things to say, but they'll come across as anecdotal or phenomenological, I think is another way to put it. And so I'm going to take a chance this morning and discuss with you the kind of health issues that have emerged in the course of my various fieldwork engagements with people in the region, and then also try and show how that is related to what we need to reconsider in terms of healthcare in humanitarian emergencies in the Middle East. If you bear with me, I'm going to give you a little bit of autobiographical detail, taking the lead from Tanya, because I think also it helps you to contextualize where I'm coming from and perhaps to understand some of the basic empathy that I have for minorities, disadvantaged groups, and so on. So I will start by saying that I, very early on in my life, became quite interested in people who lived in impermanent structures. So people who lived in tents, whether the tents were black or were white, didn't really make any difference. And for those of you who are not quite getting what I'm talking about, I spent my childhood in Damascus, and I used to accompany my father, who was an eye doctor, and used to occasionally borrow his brother's car. There weren't many cars in Damascus in the 1950s, but he would occasionally borrow his brother's car and go out to the edge of the Ghouta and provide some sort of pro bono work for the people in the white tents, or these are the Palestinians in the UNRWA tents. And I would go with him, and occasionally on his way back to Damascus, he would stop at some black tents. And these were the tents of the Bedouin. And I was very curious, quite early on, why, when people from the white tents left the vehicle, he would just take another patient, and so on. But if he had a patient from a black tent sit in the car while he proceeded to carry out some procedure, when they left, he would spray the car with DDT. And I think as a 7, 8-year-old, that I didn't quite understand, and I began asking, and that's when I realized that there was some serious discrimination against people in black tents, but not so much people in white tents. So with that, I can probably now give you an overview to say a little bit more about my background, who I am, how I got to be where I am. Then go over some definitions, which I think are important to us here, because we talk about humanitarian crises, we talk about refugees, we talk about forced migrants, but all of these are very special meanings and have particular implications. I then will go over 3, I said case studies, but they're really 3 very simple, elaborated, anecdotal discussions of various communities I've worked with. And I'll come close to closing to discuss a few of the normative and ethical challenges in relationship to dealing with certain health issues in the region. What I hope I'll be able to achieve in this talk is an argument to recognize the pervasiveness of NCDs amongst the most extreme communities, people considered generally backward, not developed, nomads, as well as various refugee communities in the area. Okay. So as my 2 introducers have said, I'm a social anthropologist. I was trained in anthropology at the University of California. And I came to Lebanon in the 1970s to try and find a Bedouin community that I could study. I had a particular community in mind because I had come across a PhD dissertation of the son of the emir of a big tribe of the Al-Fadl that had been conducted at the LSE under Sir Raymond Firth. So I was determined to find this tribe, which I knew moved between Homs and the Baalbek, and even down as far as Marish, Bar Ilyas, Ab Ilyas, and so on. And I spent a few months in Beirut asking questions, how can I find Bedouin, etc. But in the 1970s, the answer was always, there are no Bedouin in Lebanon. Eventually, I found someone who knew that there were, and I was able to join a family of the Fadl, who had some structures near Tel Aviv, which wasn't very far from the AUB farm, and also to join some families of the Hassana tribe, which also had a very long existence in Lebanon. Many people have said, oh, these are Syrian. But in fact, these Bedouin had been in the Bekaa Valley. They were known to be in the area going back to the 13th century. So in some ways, you could say they predated the Lebanese state. But their leaders, both the Emir Faour and the Emir Milham, had fought with the Emir Faisal against the French and were determined not to be taken over by the French mandate. And in their defeat, they had advised the people who attached themselves to their leadership not to register in the 1932 census. So, although there were Bedouin in Lebanon, 2/3 of them were stateless. They had no identity papers. So when I joined them at the time, I had assumed that it wouldn't be very long before they received their citizenship. The Emir, who lived in a very luxury flat down by Raushe, was in negotiations with, I think it was Walid Jumblat's father, is it Kamal Jumblat? So it was assumed that eventually these people would get their citizenship. What I didn't know at the time was that some of the Bedouin were also refugees, because some of the Bedouin were groups that had, of the same tribe, the Al-Fadl tribe, that had been in the Jolan, but in 1967 had lost their grazing land, so they had come into the Bekaa. So amongst these people who moved were also refugees, but they had a vibrant economy, they lived on the margins of the state, and they were generally ignored, which for Bedouin isn't always such a bad thing. And healthcare in those days they paid for. And after I finished my dissertation, which some of you know is called From Camel to Truck, which showed the kind of innovation that can take place very rapidly, I went back and finished my dissertation and then returned to AUB. So my first teaching job ever was here at AUB, which I commenced in September 1975. Which was not a very good time to start teaching at AUB, but it was a very interesting year. I did last the entire year until 1976, and I left Lebanon as the Syrian troops came into the country to protect some of the factions fighting in that civil war. A few years later, I moved to Oman and began working with the UNDP on a 4-year project to extend government services to the nomads of the interior on the edge of the empty quarter in such a way as not to force them to be settled. And this project, I was fortunate to be able to persuade the UNDP to allow for 1 year just an anthropological study and then the development of action plans based on the needs and perceptions of the people themselves. Having said that, it only took 2 or 3 months to realize that we did need to try and do something to prevent another outbreak of a measles epidemic, and so we did actually include an expanded immunization project. And I will talk about that experience a little bit because it does say something about the way in which we, and I'm using this as Western educated specialists, often look at the other. One of the trends that I noticed in that particular project, and I'll try and bring that up here as I proceed, was that within development, a trend which I see very clearly in humanitarian aid has moved in. And this is that within development and in humanitarian aid, you find that women and children of childbearing age are generally the focus of assistance. That services are largely curative, with the exception of the immunization program, but both within many of these development projects and in humanitarian aid, there's very little interest in men's health, or in women's health, actually, outside of the framework of reproductive health. And I can still recall in my early experience in Oman with a professional medical team accompanying me every month to do our expanded immunization programs and giving women of childbearing age tetanus injections and so on. Men coming up to us and asking if there wasn't something we could do for them too. And I could observe the kind of twittering of the medical team And then eventually somebody saying, oh, we'll just give the men some distilled water. But actually what they were asking was something to assist them also in their reproductive needs. But that was not taken seriously. Now, of course, I'm talking about at this time in the 1980s, but I still believe that men's health needs are not taken seriously within the humanitarian aid world, and that's moved very clearly into the development world. What I found also at this time, and I'll develop a little bit more, was that although these people on the edge of the empty quarter were considered to be backward by the rest of society and their health needs were considered to be very simple, here was a community that really suffered from chronic bronchitis, from asthma, and emerging problem of diabetes, which was troubling to the medical team because they were really concerned about any diagnosis of a chronic illness, because how would they ever be able to follow the people, because they moved, they didn't stay in one place. And they were more fearful of providing some assistance and then not being able to follow up, or at least that was how they put it. Later on, I came to Oxford in the mid-1990s, and I began working with refugees in the region, first with Palestinian refugees, and then with Sahrawi refugees in Afghanistan, Sahrawi refugees in Algeria, Afghan refugees in Iran, and then Iraqi refugees in Syria and Jordan, and now I'm beginning to work with refugees from Syria. It seems with all of these, the case is that because people move or people are out of place and they're unpredictable in their movements, those contacts that they've had with medical teams have the same question. How can we keep track of people? How can we deal with anything but the immediate emergency? And these questions led to either chronic conditions not being identified or not being followed up. That reminded me of my experience with the Sri Lankan doctors who worked with us in the middle of the desert, very afraid of even extending an immunization program to children because his fear was, how will we recognize the children again? How will we get them to come back? So it's this people out of place, or people who move, people who don't stay permanently in one place become a problem then for healthcare provision. But even worse than that, when people do move around and they show up, I remember a patient presenting himself to a clinic, again in Oman, with a little small brown envelope of tablets, which he handed to the nurse. The nurse took one look at them and threw them away. No follow-up, no records. And who knows what condition he had that had been diagnosed somewhere else, but there was no way of tracking this particular person. This happened 25, 30 years ago, but last month I was in Gaziantep, and I ran across an elderly man who was waiting outside of a clinic. He also had a little brown paper sack of tablets, and I asked him, what was wrong with him? He didn't know. And he didn't know what the tablets were for, and he had run out, but he didn't know how to get any more because they were prescribed to him by a doctor in Syria, and now he was sitting in Gaziantep. He couldn't speak Turkish, and he hadn't yet been able to find that person who would be able to assist him. But it seemed to me that this is guesswork. He probably had some kind of a chronic condition and would have to start all over again. Let me just take a few minutes now to do a little bit of definitional work. We talk about refugees. We talk about forced migrants. Sometimes you hear the acronym IDPs, Peoples of Concern, stateless people. I just want to get across the idea that when we're dealing with humanitarian emergencies, we're generally dealing with people who are out of place. Even if they're mobile, even nomads can become refugees, if I can put it that way. But all these terminologies, I think it's part of human nature to create descriptive frameworks, categories, typologies for people. It's a way of organizing ourselves and our surroundings. So who is a refugee or who is a forced migrant? What's the distinction? Also, what's the distinction between a forced or a voluntary migrant? These are all ways of conceptualizing the other. I'm sorry to use this anthropological terminology, but I think it's important. Within anthropology, we have the notion of ourself and others, and the others can be minority groups, they can be various ethnicities. It's a way of determining who are inside, who are outside. And also it kind of defines whether you're settled or whether you move around, whether you can be found easily or whether you are elusive. And all of these are just descriptive categories, but let me just go over a couple of important definitions which I think are worth considering. The UNHCR, the UN Agency for Refugees, the main agency for refugees in the world, uses a definition which comes out of the 1951 statutes, which defines the refugee as a person who, owing to a well-founded fear of being persecuted for reasons of race, religion, nationality, membership in a particular social group, or political opinion, is outside the country of his nationality and is unable to or unwilling, owing to such fear, is unwilling to avail himself of the protection of that country. So somebody who's lost the protection of their nation and is unable or unwilling to return. This is the official definition, i.e. somebody who's crossed an international border. You can be in that same context, a person who, again, is owing to a well-founded fear of persecution, but doesn't cross a border. And when that person doesn't come under the protection of the UN definition, it becomes an IDP, an internally displaced person. And in 1998, I would say an element of soft law was put into place, which was the guiding principles on internal displacement, which is an attempt to give some protection to people who are internally displaced but don't cross borders. And as I close this morning, I'll go over some of the ethical problems with making these kind of distinctions of people who cross a border or don't cross a border, but from the same conflict end up being given quite variable protection by the humanitarian aid regime. There are other definitions. A stateless person, I think that makes sense, somebody who has no nationality. We're aware of that here with Palestinians, with some Kurdish groups, with some Bedouin. And then there are many other definitions thrown around. I won't go into too many of them. But I will say a little bit of UNRWA definition. The UN Agency for Palestine Refugees has a different definition, which is based on territory. The definition of a Palestine refugee is any person whose normal place of residence was Palestine during the period of 1 June 1946 to 15 May 1948, and who lost both home and means of livelihood as a result of the 1948 conflict. So even the definition for a Palestine refugee within the UN system is quite specific and excludes almost as much as it includes. So I think the questions we need to think about is who's a displaced person? What is displacement, or what is in-placement? There are some cases of people who are vulnerable because they can't move, or they're in a particular place that they're afraid to leave because if they leave, they lose everything. In anthropology, we spend a lot of time looking at the distinction between a physical space and the social place, so the home and the homeland. And these ideas, I think, are also important for us to consider when we talk about a refugee or a forced migrant. But I think the main point I want to make here is that being a refugee is not a label for a special, generalizable kind or type of person. It's simply a descriptive rubric that includes within it a world of socioeconomic statuses, of personal histories, and of course, psychological situations. How a category of a person or a label is related to identity is another question I think we need to consider, and how that identity is relevant to healthcare, particularly in humanitarian crises, is also important. And hopefully I will say enough about it that it might raise some further question or discussion as we go on. Let me just give you now 3 case studies. I'm going to start with the first one here in Lebanon. As I mentioned, I did my basic fieldwork in the Bekaa Valley in 1973-74, working with Bedouin al-Fadl and the Al-Hassana. And I put this picture up because this was a picture that I took of a wedding in 1973. And in 2005, I had the wonderful opportunity of returning to this community to identify some key informants for an EU-funded study on the way in which Bedouin access healthcare in Lebanon, and part of the study was also in Jordan. So I went back to the community and I took this photograph with me in order to try and identify the people in the photograph. What really astonished me was that I found the women. And this whole group, we were all at that time in our mid-20s. So some of the men, obviously the man in the front of the photograph was much older, but most of the men were somewhere in the age of 25, 30. But I couldn't find any of the men. And when I asked, the women said to me that, well, their hearts had stopped, or they became tired. They were all dead. I know that men die earlier than women, but I found it really quite shocking to go back and to find that all of the men in that age bracket of somewhere between 55 and 75 had died, but all the women were alive. And it made me then start to question. The women who were alive were also not in very good health. Most of them were overweight and suffered from diabetes, and some of them had some kind of undiagnosed problem of breathing. And forgive me, I'm not a medical doctor, so I can't, I might say something that you're going to think this is not really correct, but had trouble breathing upon movement, so either some kind of congestive heart failure or chronic bronchitis, or I couldn't say exactly, but they weren't in good health, but they were alive. However, all the men had died. And it really started me thinking about what had happened to this community. Well, first of all, I discovered that in spite of all of the negotiations that had taken place in the 1970s for these people to be given citizenship, very few of them had citizenship. That at this point in time, there were about 150,000 Bedouin in Lebanon, but only 50,000 of them had citizenship. 2/3 of them did not. And that even outside of the context of humanitarian emergency, it seemed to me, from the fact that so many of the men had simply not survived into their early old age, that there were some silent killers around, whether it was diabetes or high blood pressure. I couldn't say, but certainly that was my suspicion. And that suspicion was also based on what I discovered in the course of my fieldwork, is that their health-seeking behavior, and this emerged very clearly in our more recent study in between 2005 and 2010, was that this community did not seek health care, did not seek assistance, until whatever was troubling them had become debilitating, or I'm going to say life-threatening. So if, for example, they had high blood pressure or they had diabetes, they wouldn't be seeking health assistance until the symptoms were severe. And this community, although settled in the Bekaa Valley, was a community that I'm going to say was out of place. It had no access to health care, and it had very little access to health education. Unsure of the signs of illness to be aware of, and certainly no routine screening for blood pressure or sugar levels. And I personally believe that that is probably one of the reasons why the men died early. But I just put that forward to you. And of course, the health beliefs were different. Again, as I said, most of this community would not present to a physician unless they were in a very advanced state of illness. So that's the case that I think you can probably relate to much more easily than this case. I mentioned I spent time working with nomads in Oman on the edge of the empty quarter. And here, I think perhaps throughout the region, political agendas have an awful lot to do in terms of what kind of medical structures exist. And in this area of Oman, the representatives of the province are able to put a lot of pressure on government to build hospitals. And this was one of the new hospitals that I visited in 2012. It's a 50-bed hospital that has adapted to meet the needs of this largely mobile pastoral population, but also a foreign or expatriate, also mobile, skilled and unskilled population in the oil industry. It works with a population that is still mobile, but much less physically active. In other words, they're using trucks to move around. Instead of using camels to transport, they're moving around by trucks. They're still in the desert. There is some physical activity, but part of this community has settled, and the diet has changed quite dramatically, and they've begun to move into eating packaged foods. And it's very clear that obesity has become quite prevalent, as well as diabetes and high blood pressure. However, those who remain in the camps have a more occupational kind of illnesses that many still suffer from bronchitis, asthma, and other respiratory problems, probably due to inhaling particles and numerous sandstorms. But let me just say a little bit more about this hospital. I've outlined, see if I can get this, yes. I've outlined the area that I'm talking about on the edge of the empty quarter. This is an area that is about 4 times the territory of Lebanon, and right in the middle there's one hospital. Of course, the population of this area is only 40,000 people. And if you consider one hospital for 40,000 people, but that large of an area, then you can probably understand why the hospital has hardly any patients. Most of the activity is through an outpatient polyclinic. But the hospital has adjusted and responded to the health demands of women of reproductive age, of children, and also minor injuries of oil workers. But still, even in this hospital, it seems that healthy, I'm going to put that in bracket, adults between the ages of about 30 to 70, particularly men, are simply not on the radar of health services delivery. So although it's a rather sophisticated hospital/polyclinic, again, the focus is on these particular elements of the population. Again here, the health beliefs differ quite substantially. These individuals are less likely to present to a physician, again, unless they have a life-threatening or life-altering set of symptoms. And pluralistic health behavior is very common. So the modern biomedicine is sometimes approached, but as much as biomedicine is looked to, so to our traditional healers and herbalists. And in cases of mental distress, or what they consider sometimes as spirit possession or seizures or trance, the people they call the Mutawwa, I'll call him the local psychiatrist. So there's a multitude of health-seeking behavior, even in this very modern and very expensive hospital/clinic in Oman. The point I'm trying to make is that there are, again, even in this very remote corner of Arabia, obvious problems in terms of NCDs, but not very well addressed by the health service. And now I just will turn to the refugee element. You all know, you're so close to it, that there are many refugees from Syria, not all Syrian. There are, of course, other groups. There are Palestinian refugees from Syria, there are Kurds, there are Turkmen, there are Sudani, Somali. But let's just focus on refugees from Syria a moment. I spent some time in Turkey last month, and in Gaziantep I had the chance to interview a number of Syrians. And I want to focus on young people for a minute, because in Gaziantep there is a population of about 50,000 young people from Syria in Gaziantep. Most of them have had to stop their education, and they are working at sometimes unskilled jobs to support their families, and they're also facing growing tension between the refugee and host community. Some of the tensions are similar to those that are being experienced here. The difference, though, is that in Turkey, all refugees from Syria have access to public medical care in Turkish facilities, clinics, hospitals alike. However, the services are unclear, and the health-seeking behavior is unknown. And many young people have begun to express fear of stepping out and identifying themselves as refugees, fear of attack and reprisals. This is particularly after the set of violent demonstrations which took place in Turkey in October. But what I have seen, and what I found really quite interesting, because it emerged spontaneously rather than as a program or project that was imposed by the international agencies, was the way in which art has begun to be used both within the refugee camps set up by the Turkish government, but also within the various communities where Syrian youth are gathered in large numbers. And I did talk to one NGO, Mercy Corps, which holds regular art contests. You might say this is a form of psychosocial support, but in these art contests that they were holding throughout the summer months, their study showed that distress, trauma, and violence arose in the work of about 40% of Syrian youth who entered these various art contests. And when I visited the Turkish camp at Nizip, I was also shown the art contests which the young people themselves had decided to organize. And this is just one of the many images. I don't know if you can make this out, but you can probably imagine this is, again, an image of death and destruction by one of the young people. But they found that this kind of use of art, a way of sort of having an aesthetic expression, was very useful. And in a way, it was a spontaneous activity which mirrored what a number of psychiatrists in the UK have written about. I don't know if any of you have read Mina Fazl's work, which she published in The Lancet in 2012, but her study showed that exposure to violence is a major risk factor for depression and other mental illnesses among refugee youth, but that living in a stable environment where they have social support outside of their home country can help significantly to lessen that trauma. So it's still very early to assess the percentage of young people who've witnessed or experienced violence and thus the prevalence of trauma-related mental health issues. But it does seem to me that the humanitarian aid regime has a slogan now that's called No Lost Generation. But they don't really seem to have many practical programs in order to make that a significant activity. No Lost Generation should mean more than just seeing people through to getting a high school diploma, if that's what they mean. It also means working with the adolescents and young people displaced by crisis in such a way that they can help themselves and deal with their very understandable depression, or if you prefer to use the word trauma, that's also quite relevant. Now you all know these numbers, but I thought it would be worth just flagging this. Obviously, refugees from Syria as of last month have reached a huge number, over 3 million. And Lebanon has an immense burden, especially compared to the size of its own population. But the burden is also significant in Turkey and in Jordan and in other places. I don't think the numbers are expected to rise much more unless, even in Ain al-Arab or Kobani, I think there's very limited civilian population. But what few people know is that the UNHCR has begun actually now a program of managed voluntary return to places like Homs, parts of Aleppo, and also Damascus. So the point I'm trying to make is I don't think we're going to see a larger crisis, but what we have now before us is what I think we need to consider. And the point I really want to make is that this population on the Eastern Mediterranean, the refugee population, it shares many of the health needs with the population of the surrounding area. They all have problems of undiagnosed NCD, but it's compounded by their being out of place, of being unwanted and largely invisible to standard health delivery systems. just want to re-emphasize the significance of the refugee population. And I'm not even talking about internally displaced. I'm just talking about the refugee population, those people who've actually crossed a border. The UNHCR gives a figure that shows that about 22% of the world's refugees are in the Middle East and North Africa. Of course, they exclude Palestinians. But if you add the Palestinian population, the refugee population, then what you have in this region is that nearly 50% of the world's refugees are in this region. And then on top of that, this very heavy burden, what I've tried to show through these various anecdotes is that NCDs and the related care needed for NCDs needs to be actively promoted and planned for among the citizens, amongst the poor, amongst the migrants, whether they're forced or voluntary, amongst the refugees, and amongst the stateless and other peoples of concern. Now, I started by trying to say that definitions are important. It's important to understand what is meant when people talk about refugees, but then what does it mean when you talk about an IDP? This makes a lot of difference to the humanitarian aid world. And I'll just give you a small example. At the present time in northern Iraq, a person who is classified as a refugee will receive support and assistance from the UN Agency for Refugees, from UNHCR. A person who does not have that label, who is an IDP, doesn't get support of UNHCR, but there's now another agency, which we call OCHA, that tries to provide some support. But on top of that, there are donors who will say, for example, we want this money, and one very wealthy Gulf state has just recently given $500 million, but they have said that this money is only to go to refugees and not to IDPs. So we actually have a case where people fleeing the same crisis, out of place, displaced, all possessions lost. But if you cross an international border, then you're going to get assistance. If you didn't cross the border, you don't get assistance. I find this really an ethically challenging problem, which I do believe needs to be addressed. I believe that the future is with our children, but I find it difficult that we so prioritize assistance to children almost over adults. The UNHCR's mandate is generally extended to the under-12s, but the future also includes adolescents, and adolescence doesn't necessarily end at 18. And again, I say, what about those who are over 30, who seem to be not on the radar at all when it comes to providing health care? And the gender dimension, which I mentioned a little bit earlier, I would ask again, why are male health care needs not considered appropriate in emergency health care, when women's reproductive needs certainly are? And also the whole issue of psychological stress. I'm trying to avoid using the term PTSD. I'm not a very keen fan of PTSD. I think it's such an American label. I believe that, that certainly distress and trauma exist, and there are other mental issues. But it does seem to me, and this was brought up yesterday, and it's important for us to consider that not all of these various conditions of mental health respond to what in the West we like to think of as talking therapies. The distress is there, but there are other approaches, and I think the spontaneous reliance on art amongst the refugee youth in Turkey and Gaziantep is particularly telling. This didn't come out of a project initiated by an NGO, but it came from the community themselves. I think these are really worth considering. So finally, I just want to again re-emphasize that whether in humanitarian emergencies or in other conditions where people are out of place, we need to recognize the pervasiveness of non-communicable diseases amongst them, whether they be refugees, whether they're migrants, or stateless people, or others in the Mediterranean Rim. These are ordinary people in extraordinary circumstances. They're out of place, they're unsafe, they're unwanted. And again, as I tried to show, many have long-term and chronic healthcare conditions undiagnosed, as I tried to point out, even amongst the nomads on the edge of the empty border of Oman. And certainly, I think that RESCAP and certainly the public health regime needs to take account of NCDs in a part of the world, which now hosts over 50% of the world's refugees. People that are not always easy to find. As I said, I'm overusing the term out of place, but they are the other. They are the unwanted, but really they're no different than you and I, except that they've had their homes blown up before them, or their families killed in front of them, and they fled for safety. So with that, I'll close and see if we have any questions.
Thank you very much, Professor Chatty, for this thought-provoking lecture that, of course, raises a lot of issues and also shows how certain case studies can actually illuminate the problems that we were discussing in this conference. I'm sure there are a lot of questions and comments, so I open the floor for, we'll start there. Yes, from this floor.
Thank you very much. Hamid Hussein from Iraq. Well, when we are talking about the humanitarian crisis, actually we are talking about short-term needs, meeting short-term needs of the population who are displaced or refugees. And this short-term, it's just like first aids or reliefs or rapid assistance. But I mean, when those people come to be a refugee for a very long time, years and more than this, then we need to think about the long-term care of medical care, how we have to engage them in a certain healthcare system, whether the healthcare system in the country that they become refugee in, or to create a new healthcare system for them. So, I mean, still we are talking about the short-term, meeting short-term needs of them. How we can talk about to meet their long-term needs in terms of chronic disease, in terms of other needs. So how to describe this issue for this population? Thank you very much.
Professor Chatty, can I mean, just to manage time, I'll take 2 more questions and then if you could respond. Here. Okay.
Thank you, Professor Chatty. You mentioned the difficulty of follow-up with chronic illness when people move, and a number of patients that came to you with medications and they didn't know why they were on it. Isn't this more indicative of a deep paternalistic attitude among the medical profession of not educating their patients about why they are on certain medication and seeing management of health conditions as the patient's management, not the doctor's control over the patient? I, as a clinician, saw many refugees are on arrival from the Middle East, and very few had any idea about their health condition. So I think it's a more problematic than the medical profession.
Okay, I'll just take another question before can you then go back to Professor Chatty. Can you bring it here?
Please.
Yes.
Sorry. Thank you very much, Ms. Fly from the UB. Actually, even with my medical background, but I will not ask about NCDs and what medical issues. I will get the opportunity that you are here to ask something about. I think that you work a lot about. Thank you also for putting this question on distinguish between refugees, internally displaced, and men, women health. Taking all that together, I think the issue of politics still a major issue when talking about all these definitions that come from, international organizations and agencies, because of ignoring what I think is another dimension of that, which is history. History in the region is one of the major issues that's shaping sometimes the definition of a group of population. Just to have an example from the Syria crisis, yes, because there's refugees that went out across the border, they get assistance and labeled by the neighboring countries. But that's the same inside Syria. People that moved, which is like almost 7 million now, moved from, let's say, eastern Syria, Deir ez-Zor, eastern Halab, to coastal side, they are also labeled, and now they are the same way that are labeled outside. So the issue of, that's not because they just, burden on the system, and that's also because they think of how to look for the others. And at least my experience from Syria, being Syrian, that the identity is so strong. Being from Halab or Deir ez-Zor, this is a strong issue. So, and moving from the place, which is a cultural place also, not just a physical one, that means you're out of that, and then you'll be exposed either to this labeling or. So how do you think that we can put this also another, dimension of the problem, which is history? Thank you very much.
Okay, so let's hear from you, then we'll again open the floor.
Okay. Hamad, let me talk about your concern about short-term needs and versus the protracted needs when refugees not need long-term care. I think what I'm trying to say is that even in the short term, there are people who have chronic conditions which need to be addressed. And I can just give you a small anecdote. In 2012, I think when the Médecins Sans Frontières first came to Lebanon, two of their colleagues came to visit us in Oxford, and they expressed to us their surprise. They came to Lebanon and they brought with them the template, the package that they use for providing emergency health care in Darfur, in the Sudan, in central Congo, in all parts of the world. And they arrived here in Lebanon and they were surprised that they didn't have to deal with infectious disease. And I said, why were you surprised? And they said, well, that's our humanitarian aid package template. I said, well, why don't you look at chronic diseases? Why don't you look at, things like, talking as a non-medical person, diabetes, high blood pressure, blah, blah, blah. These are the problems of the region. Why should it, because you're a refugee, you don't have these problems anymore? And in fact, Médecins Sans Frontières is a very, very proactive agency. They have now completely changed the way that they are approaching healthcare delivery here in this emergency for refugees from Syria, and they've recognized the significance of looking out for obesity, for high blood pressure, also for various cancers. So I agree with you, certainly as situations become protracted, we need to think about long-term care, but we need to think about people's care who are already in situations where they have chronic illness. And that unfortunately is something you find throughout the region. As I was trying to show, whether you're in the middle of the desert or you're in an urban center, you still have these same problems of diabetes and high blood pressure and so on. The question about follow-up, yes, it is a very deeply paternalistic attitude, and of course the examples that I gave are already marginalized groups, people who are already regarded as the other, not like us. But I've seen this in many ways, but I've also seen it in the West. I have a colleague who has high blood pressure and he has some problems with his prostate, and he has about 8 different pills he has to take every day. He doesn't really know what they're for. Nobody's ever sat down to explain to him that this is for this, and this is for that, and this is in the morning, this is in the afternoon. And if you can imagine an educated person with a higher degree, still doesn't understand what all their medication is about. It isn't surprising that in this region, when you have an uneducated person who has a very plural medical belief in terms of healthcare, doesn't get a sense of what these tablets are for. It doesn't take very much in order to start trying to explain in a way that would be comprehended, but it isn't done, it takes time, and most doctors don't have time. But then maybe this is something that could go into nursing care. While yes, politics is extraordinarily important even in healthcare. In humanitarian assistance, these are Western templates that are brought in. And you talk about history. I thought you were going to go a little bit further, because one of the things that I generally like to talk about is how interesting and how different things were during the end of the Ottoman period, during the Tanzimat period. The Ottoman had a very different sense of how to deal with forced migrants. And their idea of how to deal with forced migrants was finding ways to integrate them locally in various communities spread out within the region. So there was local integration, and the local community worked very closely with these migrants, whether they came from Bulgaria or from Cherkasy or Abkhazia or wherever. And this model remained until 1951. Even after World War I, when the League of Nations adopted what was called the Nansen Passport to allow refugees to move, the passport was only for them to move to another country and then to be able to start working. But after 1951, the whole idea of what is a refugee and what rights should a refugee have was transformed by the 1951 Convention. If you think about it, the 1951 Convention was really written for refugees from Eastern Europe fleeing communism. It was updated in 1967 with the 67 Protocol to extend to the rest of the world, but it basically identified refugees as something very different, as people who should be granted asylum but had no right to work. So if you can imagine that you suddenly lose your home, you leave the country, and whatever your profession, you're a doctor, you're a nurse, if you become identified as a refugee, you don't have a right to work anymore. This somehow, to me, is a template that we need to rethink. And of course, in Lebanon, for different reasons, you don't even have a refugee category, because Lebanon, Syria, Jordan, all these countries did not sign the 51 Convention, but that's more because of the politics of the UN Agency for Palestine Refugees, and also a sense of responsibility for your Arab guests. But Lebanon, somebody entering this country who has lost everything in their home country doesn't have a right to work either. And there are many reasons for it, but I do think we need to rethink history, we need to rethink the examples of the past, which didn't include enclosing people in small spaces, encampment, but really was about dispersal and integration with local communities. Of course, in Lebanon that's very difficult because the numbers are so high, but it is certainly, I think, a more effective template than the one we currently have, which I'll call the Western aid regime.
Thank you. Yeah, this side, please. Excuse me, with the microphone. Hello? Yeah. Can you? Yeah.
Fascinating talk. Thank you. What I missed in the talk is examples that that perhaps could share with us, which is the voice of the refugees and displaced themselves, except for the Palestinian refugees, where we can easily think of political movements that represented them, whether it's the PLO and others. And so we, in our minds, we know that there were organizations or representatives that spoke in the name of Palestinians. I didn't. So in your experiences around the region, who speaks for those refugees and displaced? And who are their representatives? Who fights their cause from within?
Okay, here, please.
Thank you, Dr. Chatty. Very much thought-provoking. Actually, I didn't know about the Ottoman thing, but I was going to raise something similar. The question is that we create dependency amongst the refugees. I'm going to give you an example, and of course I'm saying it just without any political. You have the Armenians and you have the Palestinians. Hey, how wait, my man. In Lebanon, we've had the refugees, the Armenians, because of the Ottoman Empire, and they had Palestinians. The Armenians were also supported initially, but then they were allowed to really work, and they became, perhaps, at least in my opinion, some of the very best citizens of Lebanon. I don't think in Lebanon you have people who do not know or who do not think that the Armenians are very capable, very laborious, etc. Versus, for example, the Palestinians, whom you, for example, you can find that they have remained in camps, etc. They're not allowed to work. Or the Syrians now. The question is that, I'm not talking about Lebanon, I'm talking about the world. These are, I'm sure there are other examples that I'm not aware of. The people that came from the Soviet Union, or does it take to really change the international vision about how to really work? You see, in theory, you don't really need to become citizens of a country. You can become allowed to work and encouraged to work so that you become less dependent, but you don't really need to vote. So maybe one of the things that you should, given your being at Oxford and really think about a different model of care and of support to the refugees. Not only provide them for immunization, but maybe provide them with training so that they can become very useful citizens. Thank you.
Okay, unfortunately we don't have any more time. We can discuss over coffee, please.
Professor Moy, I think your question is extraordinarily important. The voice of the refugees. This is an area that I've been trying to work in for a long time. Initially, I was trying to raise the voice of refugee youth because they were always being silenced. Certainly now with the current crisis in Syria, nobody is speaking for the refugees. The refugees aren't organized in the same way that the crisis developed, there was no single unified opposition. In the same way that there's no single unified opposition, there's no single voice for a refugee. They've been silenced, and I think this is what we really need to consider very carefully. I think whatever research we do now has got to be participatory. It has to be listening to the voices of the refugees to understand their perceptions of their dilemma and also their aspirations for the future. Those people who I've talked to so far are still talking about going back. We're still only, most of the dramatic flight took place in 2012, so we're talking about 3 years. Maybe after 5 years, if we're still in this context, we'll be looking at people saying different things. But certainly, what I'm hearing a lot is needing the right to work, needing some kind of what we call in sort of humanitarian aid speak, temporary protection. Temporary protection doesn't mean getting citizenship, but it means being allowed security of knowing that you can get a job, being paid the same as a worker in the country for as long as you have to be there before you can return. Now, I'm going to avoid using Lebanon as an example, but I'm going to use Turkey for a minute. Turkey is a democracy. It might be very authoritarian, but it's a democracy. And it's opened its borders to Syrians. It's taken the same number of Syrians as the Lebanese, but it has a population of about 80 million compared with the 4 million here. It has passed a law which is supposed to allow Syrians residence rights and rights to work, but it hasn't implemented them, and so Syrians are unsure. What is needed is a sense of security, that it's okay to work. And if those of you who were following the news in all the demonstrations which became very violent last month, the problem is that Turkish people are beginning to be very nervous that Syrians are taking their jobs from them, because Syrians don't have an official right to work, so they can be hired and paid less than a Turk. They don't have to pay social security. So this has created a divide. In order to move forward, we have to find ways of allowing the refugee to have voice and to be treated, at least temporarily, like a national with similar rights. I don't really see Syrians as refugees organizing themselves in the same way that the Palestinians were able to, but then I hope we're not looking at a situation 60 years down the line.
But it took 20 years for the Palestinians to organize.
It did. As you said, it took 20 years before the Palestinians organized themselves. But I'm still an optimistic pessimist. I don't think this crisis is going to take 20 years. It can't. It's just, that whole region will implode if this carries on for too long. And the question about, yes, of course, we are creating dependency when we don't allow people to try and find livelihoods. This is a problem, and the vision does need to change. And I think, the humanitarian aid regime is like a big dinosaur. It takes a long time to turn around, but it's moving in that direction. There's more and more work now coming out in international law demanding temporary protection rather than, I'm going to say, full long-term rights. If some of you know Susan Akram, she's done a very interesting study in this region where she's also calling for temporary protection. In Oxford, we did a similar study for Europe and the UK, calling for temporary protection. Because, of course, I haven't talked about Europe or the UK, we're looking at the region, but if Europe were to drop some of its fortress mentality and stop putting so much money into this agency called Frontex, which prevents people from getting to Europe, and took a little bit more of its fair share, we may also see some sort of easing. And I think we're moving in that direction. We know already that Germany has taken 200,000 Syrians. If every European country took something like that number, it might leave breathing space for a country like Lebanon, which really has an amazing burden to try and manage.
Okay, so with that note, we close this session, and thank you again.